Assalamu alaikum. The clinical day, starting with this scenario, Mrs. Julia, 35 years old, referred to your clinic with complaint of headache. The vitals are all normal, so we can start after sharing the time with the patient, if you're ready.
Okay, let's start.
Yeah, here you go.
How are you? Okay, how are you? How are you, dear? I'm Dr. Asma, the doctor in the clinic today. Can you please tell me, that are you Mrs. Julia, 35-year-old?
Yes, I am.
Okay, I'm here today to ask you some question and examine you. Are you okay with this?
Yes, doctor.
Okay, dear. Can you please tell me what brought you here today?
Oh, doctor, last night I have faced a severe bad headache. I'm not habituated with this kind of headache. However, for last 6 months I have headache, but last night it was worst
So
in my life.
you had a new onset headache in the last 1 month, but in the last day, or I mean since yesterday, it become very severe.
I have I had mild headache for last 6 months, but last night it was very severe.
Okay, so only from last night, the nature of the headache has changed, right?
Sorry.
Only the last night, the nature of the headache changed.
Yes, all right. That's
Okay,
right.
is it now let's talk about the severe headache. Is it continuous or on and off since yesterday?
It's continuous.
Continuous, okay. And did you try anything to make it better?
Like as before, I took some painkillers, paracetamol, but it did not improve.
Okay, and do you feel like you have any vision problem, blurriness of vision, anything with this headache?
Uh,
The new
for
onset.
last 6 months, I think I am seeing this, but it is more it is more with last night.
Can you describe for me this vision disturbance you are talking about?
All right, I am not sure, but I think I always bumping into objects.
Bumping into objects, okay.
And I can see traffic lights also.
You can see what?
Traffic lights.
Traffic lights, okay. I will come back to your vision problem. Now, this headache, which started yesterday, can you please localize where exactly it is?
It is all over my head.
All over your head. And it is getting worse or the same since it started?
It is increasing.
If I give you a scale from 0 to 10, 0 no pain, 10 maximum pain, how much you will give your headache?
It is 9, I think.
Oh, okay. And if we compare this with the previous headache, which started 6 months, how much you will give that headache?
That was around 4 to 5.
Okay. And do you feel that the headache is spreading behind your eye, spreading back to your neck?
No, it's just all over my head.
Okay. And do you feel that this pain come after a trauma, or did you bump your head or fall down?
No.
No. Okay. And did you notice that you have any, you told me about this vision problem, right? So is it this vision problem started since 6 months, or only you noticed this in the last night?
It started for 6 months, and it was more for from yesterday. It is increasing yesterday.
Yesterday. And did you have any kind of dizziness, lightheadedness,
No,
especially when you stand from sitting position?
no,
No. Did you lose your consciousness at any time?
no,
Any abnormal jerky movement?
no.
Did you notice that this headache is more at a specific time in the day, like more in the morning?
Not now, but previous 6 months, I thought, I think that was more in the
Maximum,
at the morning.
maximum in the morning. And did you notice that you have any kind of feeling sick, being sick?
No,
Any runny nose or tearful eyes?
no,
Did you notice that this headache is kind of related to any stressors, tension, working for long hours?
I don't think so.
Okay. And this is the first time for you to experience such a headache in the last 6 months. Before 6 months, you were fine.
Yes, before 6 months, I was completely fine.
Oh, did you notice any neck stiffness?
No,
Any sensitivity to the light?
no,
Any sensitivity to sounds?
no,
Did you notice that your temperature was high at any time during those 6 months or the last night?
no.
Any changes in your weight?
Doctor, I think I have lost some weight.
Lost
Not
some.
much.
Okay. And how many kg over how long?
3 kg over last 6 months.
6 months. Okay. And how's your appetite?
Appetite is good.
Good. And any kind of, you told me no dizzy spells, no loss of consciousness. Okay. Did you have any changes in your, any lumps or bumps anywhere in your body, in your neck?
No,
No. Did you notice that you have any kind of itchiness or skin changes,
no,
like decrease in the pigmentation or increase in the pigmentation?
no,
No. Do you have any joint pain?
no,
Okay. Any night sweat?
no,
Okay. Any change in your water work?
no,
Any change in your bowel habit?
no,
Any tummy pain?
no.
And okay. uh طيب. uh do you have any kind of diagnosis, long-standing illnesses you are following up for?
No,
No. Any regular medication?
no,
Any hospitalization or surgical
no,
or any kind of procedure?
no.
I will ask you some private question about your period. Is it regular of normal amount?
It's not regular.
It's not regular. So can you tell me since when it's not regular?
For last 6 months.
Okay. And what about the amount, scanty or heavy?
It's scanty and it does not maintain the periodicity. Like sometimes it's too early, sometimes it's too.
Too late. Is it possible any recent delivery?
Sorry.
Any recent delivery? How old is your youngest I'm sorry, before asking this, are you in a long-term relationship?
Yes, I'm married. I have 2 kids.
2 kids. And how old is the youngest?
Oh, my youngest one is 5 years old.
5 years old. And did you have any problem when you deliver? Like any bleeding, any blood transfusion was given?
No,
Any difficulties in feeding your baby to extent that you need to use a formula?
no,
Any feeling of tiredness and fatigue at that period?
no,
No. Okay, so it went fine. And are you on any hormonal treatment or oral contraceptive pills, birth control pills?
no.
No OCPs. Okay. Another private question. How is your sexual life? Any problem in your desire? Any problem in the intimacy?
I don't feel like doing it so much.
Mm.
I don't feel very comfortable.
And since when you start to have changes in your desire?
I guess it's the same period, like 6 months.
It's okay. And did you notice that you have, you told me no bowel habit, any weather intolerance, like you more tolerant to the, I'm sorry, you are more intolerant to cold or more intolerant to hot?
It's all right. It's not very, no, not very
Not a
problem.
problem. Okay. And do you smoke?
No,
Do you drink alcohol or have you, do you drink?
no,
Okay. And did you travel anywhere recently?
no,
Have you ever into radiation or radiotherapy for any reason when you were a child or something like this?
no,
No, or any trauma during childhood or anything,
no.
nothing like this. Okay. Any contact with sick or ill person?
No.
Do you drive?
Yes, I drive. I drive to my office.
Since you have some vision problem, okay, and you told me that you are bumping into objects, so I would advise you to stop driving, and we will update you regarding your driving, the driving regulation, okay? Especially
Okay.
after confirming the diagnosis. So, with whom you are living at home?
Well, I'm living with my husband and my two kids.
And are they supportive or you need any support at home?
Yes, they are supportive.
Okay, that's good to hear. And you didn't travel abroad. Okay. Any family history? Similar condition, like problem in the glands, some
No,
defense mechanism issues, cancer,
no,
nothing.
no,
Okay, nothing running in the family. Diabetes, blood pressure, nothing.
no.
Okay. I want to examine you. So I would like to check your vitals, blood pressure sitting, standing, blood sugar, pulse,
All
regularity,
right. All right.
anything abnormal in those parameters?
No, those are good.
Okay,
Normal.
and okay, the patient looked like I will check the skin if there's any vitiligo, hypopigmentation, hyperpigmentation, general look, and I will check her hands, nails, the skin, the cubital fossa, the elbow. I will go up proximal myopathy. I will ask her to abduct her shoulder. Any weakness,
No,
Mrs. Julia? No weakness. Okay, and any abnormal sensation?
no,
No. And then I will go to the eyes. Any pallor, any icterus,
no,
any hair loss, any alopecia, alopecia areata, nothing. I
no,
will go to the mouth. I will flip up the upper lip, the lower lip, bring your tongue up, down, the buccal mucosa, any hyperpigmentation,
no, those are
any,
good.
okay, and no sore throat. And then I will go to the neck. I will palpate any bumps or lumps. I
No.
hope nothing is there. And then I will ask her if she can see my face. What is the time now? Gosh.
Yes, I can see your face.
Okay, and then I will examine roughly the visual acuity by finger counting, light perception. I think she can count my finger, right?
Yes.
Okay, I will examine her H-shape movement, extraocular
Mm,
muscle. And please,
mm.
Mrs. Julia, whenever you see double, any pain, let me know. And I will observe her if there's any restricted eye movement.
2 minutes left.
So restrictive eye movement.
No restricted eye movement. Visual field.
I cannot see the temporal sides.
Both eyes, right? And then
Yes.
I will, okay, then I will go to the abdomen. I will check if there is any stria, distension, skin
No,
changes,
no, no.
nothing. And then I will check if there's any lower limb edema.
No,
No lower limb edema. What else I need to check? And no abdominal tenderness, right?
no.
Did I forget anything? طيب, what is your concern?
So, doctor, what do I have? Why I am having this bad headache? I heard that most of the time such bad headache leads to stroke.
The last question,
Is
just tell me, is it a
this
stroke?
stroke?
Okay, I will address this in a minute. Just one question. Did you notice that you are expressing milk from your breast recently?
Sorry, I couldn't understand.
Do you notice that you are having some discharge or milk-like discharge from your breast recently?
Yes.
Okay, so I'm sorry to ask this question now. I had to address your concern. Actually, it is not a kind of a stroke, but it is something serious and concerning. You have a kind of abnormal growth in a gland inside your brain. We call it pituitary gland. And this mass is leading to over secretion of some hormone and compressing the nearby tissue and causing under secretion of other kinds of hormones. So that's why you have disturbance in your period, disturbance in your desire. You have this kind of headache, okay, because this mass is growing inside your headache. So what we will do now is that we need to admit you. I hope this is okay with you. Is it okay to admit you, or you have anything at home?
No, I can admit
Okay, that's
myself.
good. And then we will form a multi-speciality team, mainly formed of the nerve doctor, brain doctor, a gland doctor, and we will measure those hormones and we will put you on some replacement. And we will discuss how we will manage this mass surgically or medically by medication. There will be another follow-up meetings and we will update you about the workup. For now, as I told you, since we will admit you will not need to drive, but you should be careful about this. Do you have any other concern?
No, doctor, thank you.
Yes, time is up since 1 minute. We can start now the examiner question. Dr. Tanya, please start.
What is your diagnosis?
See, my diagnosis is she seems to have a pituitary adenoma, functioning pituitary adenoma, okay, which I picked up at the end. It's prolactinoma. And this functional pituitary adenoma has complicated with pituitary apoplexy, okay, or bleeding or hemorrhage or ischemia, some acute changes on top of chronic adenoma. This is my top differential. My second differential is one of the primary headache. We always have to exclude primary headache. It can be a kind of a primary headache, and now she came with an acute attack, but this is unlikely because she's not fulfilling the criteria of any primary headache. My third differential can be any kind of a space-occupying lesion, okay? And that has now some kind of hemorrhage or some kind of acute changes on top of this chronically growing space-occupying lesion. So this is my differential, actually.
All right. So how will you investigate?
How I will investigate, I will do some routine workup, including CBC, LFT, RFT, inflammatory marker, electrolytes. I will concentrate on the blood sugar, sodium, potassium, because she might have adrenal insufficiency. I would like to do for her some kind of chest X-ray ECG as a routine. I will do for her hormonal profile, pituitary and end organ hormones. I will do MRI pituitary. I will do CT brain to exclude any space
What
occupying lesion.
What would you expect from MRI?
See, it is still acute, so there will not be an empty sella torsica, but I would find some hemorrhage, hyperintensity inside the pituitary. Do you know some hyperdense changes according to, is it ischemia or hemorrhage? And most probably it will be like, encroaching the surrounding because now she has vision problem.
All right. So how will you manage?
I will see acutely, I will admit this patient. I will provide her with fluids, hydrocortisone, stabilize her vitally, give her painkillers. She's in a very severe pain. And after that, according to the hormonal profile, if it is a prolactinoma, there could be a chance to treat medically by dopamine agonist. And if there is like, severe changes, mass effect, then we might need to intervene surgically by the help of neurosurgery. And then after managing her pituitary apoplexy or managing the acute changes in the brain, I will start replacing the hormones, starting with the cortisone, then thyroid, then sexual hormone according to her need. And I will keep an eye on the blood glucose, I will keep an eye on the blood sugar, and that's it.
All right, thank you.
You are most welcome.
Okay, no more questions, Dr. Tanya? You
I
ask about the images? You ask about the images?
sorry, sir.
What image you can offer to this patient? You ask about the scans?
She asked me about the finding in the
Yes, sir.
MR pituitary.
Okay.
Yes, sir.
Mm.
I asked what is the finding of MRI.
Mm-hmm.
Okay. And you ask for the differential, right?
Mm-hmm.
Yes.
Yeah.
Any further question you want to add?
Sir, I
Uh,
think should we ask about the drug history, any recreational drug history in this case?
no, I mean about Viva. Any question? You want to add question
Okay.
to the Viva because 1 minute left. Okay, if you don't
No,
have
sir.
question, okay, you can comment now about the case performance for Dr. Hind, then other will comment, okay?
Yes, sir. I think she's quite fine. She's done it very nicely, and as I am a beginner, I think what I usually do set of questions one by one. I think she in this case she asked some questions very randomly, and I think consequences should be maintained. Oh, I don't know what other would say.
Yeah, so
Like, is there anything missing which
yeah, what do you think?
kept
Any
it?
question, as you
Mm.
said, any question unrelated
The
unrelated to the
arrangement,
case?
I agree with you. I was not arranged, but like anything missing in the analysis, specific analysis, general analysis. I know that I asked about the test.
Clotting about the cavernous sinus thrombosis. It is a acute headache.
Yes.
So intracranial hypertension, pregnancy history should be added. Uh, though she asked me about the last age of last child. Intracranial about idiopathic intracranial hypertension, she asked about the morning headache. I think that's quite fine. Migraine she excluded, cluster headache she excluded, and I think there is no more. So far, I could understand. Nothing was much more to add here.
Yeah,
Just
yeah.
the pregnancy is should be asked. Very few more questions actually.
Yes, I agree. My comment on Dr. Hind about the origin of the macroadenoma, and you remember at the end, yeah, it was good.
معك حق
Yeah,
لأنه
yeah,
وقت اجت بدها تسألني what do I
mm,
have?
yes, exactly.
Fundoscopy should be offered also.
Yes, fundoscopy should be offered. You are totally right.
Yes, yes,
Fundoscopy, some neurological examination should
Yes.
be done, like reflexes, pronator drift. I totally agree. I miss those things.
yeah. I think Dr. Hind also the case was straightforward since the presentation seemed quite clear. I mean, since she said I have the headache since 6 months and now it's severe headache, and if you asked about is it the worst headache ever, so it will be target to the diagnosis, which is pituitary apoplexy. I think from the first question it might be right or
للأمانة ممكن
yeah.
كان ممكن واحد يعمل هيك بس it will
Yeah.
make you يعني it will drive you into the endocrine. You will forget to exclude the other things. فضليت ماشي بالسكيم تبعي.
Yes,
سألت
you
على
should exclude
المننجزم
other.
والانكريز انتركام وعملت حالي فهمت علي كم يعني
Yes, I agree.
نبيها بالquestions.
But
لكن I agree with you إنه it seems to be a thunderclap headache at least developed
yeah,
recently
yeah.
on top of a chronic headache from the beginning.
I,
Yes.
I I agree to differentiate the others, but my target now to know the origin. What was the origin? So either Cushing or acromegaly or prolactinoma, which you already got later on. I think during the investigation or the analysis, you ask about the hormonal assay, which is panhypopituitarism or non-functioning
Mm,
adenoma.
mm,
Non-functioning adenoma.
mm.
But the prolactinoma was the target. Yes, you have to ask about this question, especially
انا
she said
انا
to you.
للامانه عرفت برولكتينوما من الهايبوغوناديزم. ليش نسيت الميلك discharge لا تسألني.
Yeah.
بس في الهايبوgonadism I picked it up
Yes,
prolactinoma
of course,
بس
from
you
the
cannot
period.
tell you
Yeah,
cannot
from
tell
the period.
prolactinoma without this differentiating question.
Yes, right. Yes, you're right.
This
Supposed to ask about, especially each patient is having a period change, which is also matching with prolactinoma. But for the breast and the breast discharge,
this is
it's
very
like,
important and differentiating
yes,
question you
no,
are
yes, exactly. Yeah, this is my comment. And the time to be doing examination earlier. Also, this is
بدأت
another
على 10
advice.
11 you are right.
11, yeah. I was about to tell you it's 11 minutes, but you moved to the examination. That's why I kept quiet. But I wanted to remind, and everyone, please do examination as soon as possible. You have a
بس
lot of
للأمانة من
findings.
وقت ما سألت على السموكينج with whom you are
Yes.
living I wish I could really ask together يعني to check
Yeah.
الفيتals
Yeah,
see their
exactly.
eyes. هاي أشياء ممكن تنعمل سوا يعني at
Can be,
least
yes,
to
in the same
save
time.
some time.
Yes, yeah, I agree. I agree. Anyone has comment? Any question? I think the case is clear now. Pituitary complex after macroadenoma or prolactinoma. The differential, as usual, apoplex and Sheehan syndrome if the patient has history of delivery recently, but it's already ruled out.
هو بصراحة I was very reluctant to mention
Sheehan syndrome.
Sheehan because
Sheehan
5 years have passed. وسألت any complication she said no. Any
Yes, yes,
problem in
I
the brain.
agree. I
Yes
agree. Yes.
يعني I think you have to keep it even till the end. فممكن واحد really to mention space occupying lesion وحتى ال space occupying lesion can bleed can has infarction يعني بأي
Yeah,
مكان
yeah.
بالبرين. ف it is a good differential وال primary headache always when there is a headache acute on top of chronic اللي هي acute attack on top of a chronic course of headache يعني tension
Yes.
ولا medication overuse. ف they love this differential. I
Yes, yes.
agree with you إنه كمان at the end if he asks you what else yes you can add Sheehan and all the
Mhm.
Thunder Club headaches can be added حتى يعني
Exactly, yes. The
Thunder Club.
subarachnoid even, as I said, subarachnoid complicated chronic headache for any reason, the migraine or because it might be, or hypertensive encephalopathy, it might happen as a complication. It's not
بس
necessary to
يعني you
be,
have
yeah,
to always since you يعني this differential need a lot of assumption
of
if
course.
مثلا
If the
he's
patient,
keep it till the end لأنه she's not fulfilling. But I agree with you if he asks what else
mm,
all the Thunder Club headache can work يعني.
yes, exactly, yes. Did you do the neck stiffness test for clinic
Because when I
No.
asked her, do you have any neck stiffness? But
Yeah,
it is a
this
valid
is a
examination
must.
in headache.
Yes,
Neck
yeah,
stiffness, fundoscopy, some CNS examination.
exactly, yes. Okay, thank you, Dr. Hind. Well done, of course. And let's move to the next case. If no one has comment or question, anyone has comment or doubt, he can raise it either by writing or sharing with verbal. It's free.
هلو السلام
Yeah.
عليكم.
وعليكم السلام ورحمة الله وبركاته.
دكتورة هند well done ما شاء الله as usual. But there is one comment when you answering the examiner question you start by say see kiss
Yeah,
me
yeah.
irritate the examiner that is
لا
just
لا
for your benefit.
عادي شوفي بالامتحان صدقيني ما حتطلع حكون مرعوبة وسويتي I will be
من
very
بلا
formal.
Yeah,
because the things that you say during practice is going to be in your
yeah,
mind.
yes,
That
Yeah,
is
exactly.
I
why
agree with you sometimes yes.
Subconscious, you'll say it.
yes
Yeah, yeah. See,
فذات irritate me فما بالك الاكزامينر see
yes, you're right.
كده
Yeah.
كده كده just yeah just that for attention
Yes.
يعني nothing
Yeah,
bad you
yeah,
did
you're
well
right.
Thank
ما شاء
you
الله.
so much. I will take care of this. والله معك حق ممكن الواحد عن
Yes.
جد حتى ستريس يستخدم مصطلحات هو بالعادة.
Not only words, you can use the hands, like pointing to something, you want to point to it by using your hand. This is also not accepted there.
Not yes professional
Yes.
بالإجابة.
Yeah,
تمام.
exactly. Okay. Thank you, Dr. Sousa, for your reminder.
You are
Okay.
welcome.
Oh, thank you. Any comment before moving? Dr. Tanya, can you post the scenario, please? Sorry, Dr. Hind. You can post the scenario.
لحوني. أوكي ثواني
Okay.
خلي
Thank you.
دكتور باسم السلام عليكم.
Yes, عليكم السلام.
Well done, Dr. Hind. I just have a question.
Yeah.
In Sheehan syndrome, usually the patient will not be able to lactate, but here in the case, the patient has galactorrhea.
Yes,
So
exactly.
can we still put it a differential?
The differential here depend on the presentation, the headache, acute headache with such severity. There is limited differential. She had meningitis, subarachnoid hemorrhage, ICH, and the pituitary complex. Sheehan, we put it for the consequence of the case, prolactinoma or hypoprolactinemia. So I think, as Dr. Hen said, you can make it at the end, not the top three. The top three is meningitis, subarachnoid hemorrhage, ICH, and our case here, and venous serous thrombosis. And you can choose according to the positive find. So if you have DVT or patient with hypercoagulability, you can put the venous sinus thrombosis. If you suspect patient is hypertensive or you have patient with hypertension uncontrolled, you can put the ICH. So you can play these pieces and you put which one is prior according to the case scenario. But Shihan, yes, I agree. It might be a little differential for this case because in Shihan no hypertension and also no headache. It's just patient had history of, and now she is failing to lactate. I guess so. So yeah, I agree. It's not a differential. Okay, thank you, Dr. Ayan.
Thank you, Dr. Bassett.
Thank you. Yes, you're right. It's not the top differential. It's differential only for the hypopituitarism. By the way, the apoplexy as well, it might lead to hypopituitarism because the same action happened, bleeding inside the gland, and the gland will fail, of course, after some time. So if he asks you what else, you can say it related to this point particularly. Okay, Dr. Aisha also comment about the severity of headache. Dr. Hind, you didn't offer any painkiller?
Painkillers, maybe, yes. She said 9 out
Yes.
of 10, I should.
Yeah, 9 out of 10. Yes, it's very severe. And the admission also, you can judge the admission based on the severity of headache. So 6 or 7 and above, patient with severe headache, you must admit him to do some, at least you can do some radiological investigation or some tests to be sure that nothing is ongoing. Because the patient will not complain for nothing. 9 out of 10 means very serious.
Severe, yes, it is.
Yeah.
It fit the thunderclap. In such
Yes,
a
exactly.
severity, it fit the thunderclap.
It's okay. Your case, Dr. Hind, you sent already?
Yes, حطيتها على الجروب. أنا من
Yeah,
أول
yeah.
ما أبعت لك إياها على
No,
المسج.
no, no, no. I saw it. I saw it. Yes. 40 years.
سامحني لأنه فتحت
No,
اللينك من عندك، بس حطيتها هلا على الجروب.
no problem. 40 years old patient present with complaint of decreased urine output and nausea. Take history, examine vitals. Stable.
Vital state.
Okay, Dr. Tanya, 2 minutes. We can start after.
Sir, what is UOP?
Urine output.
Urine outputs.
Okay, I get it.
You can or say oligouria.
Is male or female?
ما كتبت مستر.
No, no.
خلينا ناخده مستر آدم سميث.
Okay, I'm writing already in the chat box, so let me write it. Okay. When you're ready, Dr. Tanya, let me know. Any other comment, please? Dr. Azhar, are you with us today? Yes, you can. We need active participants.
Hello, Assalamu alaikum.
Alaikum assalam. Yes, Dr. Azhar. Any
Mashallah,
comments?
You commented everything. Only she forget fundoscopy and neurological examination. And
Yes,
somewhat.
يعني حتى
The case
even
was,
for
you are right. The case was very clear from the beginning. It
Mhm.
was.
Yeah. Yeah, thank you, Dr. Azhar. Yes, thank you. Okay, I'm always opening the door for discussion just to get the confidence to talk. Because this exam need only to be confident and calm while you're talking. They are testing your stress control. Whenever you feel controlling your stress, you are ready for the exam. But if you are stressed while talking in a meeting, how you will do in the exam? This is the way how to get the confidence. So share with others, talk with others, get a case scenario with in the free sessions, especially those with high number or large number of participants. It gives you more confidence.
Yes, you are right.
Okay. Anyone has comment before moving to the next scenario? Dr. Tanya, if you're ready, let me know.
Okay, sir, I can start, I think.
Yeah, okay. This is the timer. Here you go.
Uh, hello, sir. Hello, sir. I am Dr. Tanya, one of the doctor of this hospital today. Are you Mr. Adam Smith, 40 years old?
Yes, doctor, I am.
All right. So, sir, today we are over here to discuss about your health condition. I will be examining you and will take some history and maybe I will take some notes. Please don't worry. It will be completely confidential with me. Is that all right with you?
Yes, doctor, sure.
Okay. So may I know what brought you here today?
Doctor, I have a kind of changes in my water work. I noticed that they are less than usual. And also I start to have this feeling of being sick, and it is becoming more frequent.
All right, I get it. And I'm feeling very sorry that you're suffering. So, uh, may I know for how many days are you noticing that your water work is decreasing?
The water work start to decrease, you can say over 2 weeks, but I notice it like, I notice a big change in the last 3 to 4 days.
Okay, so may I know, can you assume that how much you went for the waterworks?
I did
I
not
mean,
get
how
your
much?
question.
I mean, how much water work urine have you passed for last 24 hours? Can you assume that? Like
The
after?
amount you mean?
Yes.
Okay, so like it started, I usually, for example, pee twice a day. For a few weeks, it become like once a day. Recently, I go to the bathroom once, but I pass, like, do you know, something like a small cup full, not my
Okay.
usual amount. And even you
Okay.
can say for 1 day and a half or 2 days, I don't pass. Then I pass this small amount.
Okay. So are you taking enough water?
Yes, I'm drinking my usual.
Okay. So have you noticed anything increasing this problem or worsening this problem?
I cannot tell really. I don't know what could be the reason.
Okay. Okay. So can you tell me what is the color of your water work?
Doctor, it's orange, dark yellow sometimes, especially in the morning, or especially the first void. I notice it very dark.
Okay, I get it. So um, apart from this, do you have pain during your water work?
No, no pain in while passing.
Okay. Uh, so any blood,
No blood,
any gravels,
no gravels,
any burning,
no.
any back pain?
I feel like kind of joint pain all over my body. Something like as if I'm not feeling well, as if do you know the feeling after a viral infection? Something like this. It recently
It's
started
like,
to occur in the last few weeks also.
okay. So can you tell me that so do you have fever, high body temperature,
No,
any lumps and bumps in your body?
I didn't notice.
Okay. So any recent weight change?
I'm losing weight actually.
Okay. How much weight have you lost?
I lost like 4 to 5 kg.
Okay. So is it first time have you noticed, or it is you ever faced this kind of problem before?
The weight loss, you mean?
No, your urine problem.
First time.
Okay. Do you have tummy pain?
Yes, there is a kind of tummy discomfort.
Okay. So on which part of your tummy is most is pain is much?
Right lower part. He will
Okay.
point to the right iliac fossa.
Okay. So do you have any tummy swelling?
I don't know, but I didn't feel my tummy is swollen. Particularly even on over that part, I didn't feel any swelling.
Okay. Any change in your bowel work?
My bowel habit is normal.
Okay. So you, apart from feeling sick, um, do you have you noticed that your feeling sick is related to your taking food?
In the beginning, it was with the food because it started like 3 weeks ago. Recently, I'm having nausea even without taking meals.
All right.
And
So have you?
my desire to eat has decreased also.
Oh,
And
you
still the
have lost
nausea
your
is there.
appetite. All right. So do you take any regular medication?
Yes, doctor.
May I know what kind of medications are you taking?
Tacrolimus, mycophenolate mofetil, and steroid.
All right. So is there any past medical history or any surgical history you want to share with me?
Yes, doctor. I had kidney transplant 13 years ago. And I had also a hip replacement, right hip replacement. These two surgeries, major surgery I did in the past. And I had a problem in my blood sugar, but with diet, it gets better. So I'm not on any medication, just diet control.
All right. So how many days ago you went to the kidney transplant surgery?
13 years ago.
All right. So are you on regular follow-up?
Yes, my last follow-up was 1 month ago.
Was it good?
Yes,
Your kidney work?
they told me at that time that my parameters were fine. But at that time, I didn't have those symptoms, to be honest. I was feeling fine.
All right. So do you have itching?
No,
All right. So do you have chest pain?
no,
Any shortness of breath?
no,
Any leg swelling?
no,
Any racing pacing of your heart?
no,
Okay. Do you have any headache?
no,
Any history of loss of consciousness?
no.
Any weakness in your any body part?
Generally weak, the feeling I told you, as if I been been in an accident recently. My whole body is really aching, and I'm really feeling tired, but no
Okay.
specific weakness.
Okay. So all right. So any vision problem?
My vision is fine.
All right. Do you have any skin rash?
No,
Okay. So do you have any pins and needle sensation all over your body or
no,
any part of your body?
no, no,
Okay.
no.
So, do you have high body temperature?
I told you no.
Okay. So, uh, are you taking steroids, right?
Yes, yes. Part of my regimen is steroid.
All right. So, do you have any bleeding in any part of the body?
No, to be honest, they counseled me about this kind of complication or side effect, and I'm using PPIs over the counter.
Okay. So, do you feel weakness while raising from chair or
No,
combing your hair?
no.
All right. So, did anybody tell you that you are getting pale day by day?
No, not much.
All right. So, all right. So, what do you do for living?
I'm working as a postmaster.
All right. Do you smoke?
No,
Do you drink alcohol?
no.
All right. So, any recent travel history?
For the last 2 years, I'm living in UK. I didn't leave it. I didn't travel up.
Okay. All right. So, I want to examine you.
Okay, what do you want to examine, doctor?
I want to see the hands for any pallor, koilonychia, and leukonychia.
The nails seems to be normal.
All right. So I want to see the tremor.
How you will examine the tremor?
Well, I will I'll examine the tremor uh, by keeping the hands over the pillow,
Mm-hmm.
and also want to see the flapping tremor.
How you will examine for flapping tremor?
Flapping tremor, I will tell the patient to keep his hands outstretched and spread his fingers and cock up the wrist.
Yes.
Then,
And if it is not visible, what you will do?
if it is visible, then it is positive for flapping
No,
tremor.
no,
That
if
means
it is not visible, not visible. So what you will do, you will trigger it, right? By flexing the wrist to trigger it. Okay, there is a flapping tremor. The hands are tremulous when you cock back the wrist. What else you will do?
okay. Then I want to see the pulse.
Mm-hmm. Pulse is
I want to see
regular, equal, bilateral, normal volume.
blood pressure.
Blood pressure is 135 over 75.
All right. Then I want to see the eyes for anemia.
There is mild to moderate conjunctival pallor, no icterus.
2 minutes left.
Okay. Then I want to see the tongue for gum hyperplasia, oral
There
cavity for
is
gum.
good, there is gum hyperplasia.
All right, there, and then I want to examine the chest
What you
for
check?
any pulmonary edema like bivasal crepitation.
There is no bivasic crepitation.
All right, then I want to see check the tummy for abdomen for I want to see the scar mark and the palpate the.
What scar mark you are expecting?
I want to examine the scar mark of renal transplant and whether there is tenderness or not, any sign of infection.
Okay, and do you want to check any other kind of scar marks?
What other scar mark you have told? I forgot. Another surgery you have mentioned.
Yes, I will show the picture. Continue. In the abdomen, when you palpate under the scar, there is a soft mass, tender, okay, around 6 multiplied by like 11, tender as we said. Do you want to do anything else for this mass? Like a kind of examination also?
I want to hear the bruit.
Yes, you are right. There is no prurite. What else you want to do?
Then I want to see the pedal edema.
I cannot share my screen. Pedal edema is negative. What else you want to do?
All right. I want to see the fingertips for any prick marks.
No prick mark in the fingertips.
So may I know why renal transplant has been done for you? Can you mention the?
Finally, you asked a good question. I was having a kind of joint pain, doctor, and I was taking chronically the non-steroidal, and it cost me my kidney.
Okay. Okay. So what is your concern?
Doctor, am I losing my kidney? Am I losing my graft?
After examining you, currently some possibilities in my mind, and I'm afraid that there is something problem happened to your graft, new kidneys, and right now we will admit you and we'll do some test and we'll manage you accordingly. Any other question?
So, doctor, I need to be admitted.
Yes, right now I want to admit you because there are some red flag signs.
And what is the chance of me losing my kidney because of these symptoms that I have?
It will be directed by the findings of our labs, and we after having the reports we can mention how deteriorated your new kidneys are.
Okay, thank you so much.
Okay, time up since 1 minute and 15 seconds. You can start now the examiner questions.
Okay, dear, tell me, what is your positive physical examination signs?
All right, my positive findings are patient has a mild pallor and there is a flapping tremor, that is the sign of uremia. And on uremia, and there is also gamma hyperplasia, that is sign of tacrolimus toxicity. And other thing is the patient has graft tenderness. So there may be infection in the new kidney or the scar mark.
So you find the scar marks. Actually, I send you one scar mark in the WhatsApp group. So you find the scar marks of the kidney transplant. What is the scar mark which is on the WhatsApp group? I don't know why you forget this part of the past history.
It's in the chat box here also. You can find Dr. Tanya.
Yes, sir.
He gave you one history, very important history. How many surgery this guy he did?
He went for 2 surgery actually.
Yes.
I forgot.
Hip replacement and renal transplant. Okay, so you find the scar in his loin area or the upper thigh, the hip replacement scar. It can be in the buttock, it can be along the, let's say the side, like, along the side of the thigh,
Inguinal canal,
or
right?
in the inguinal. 3 scars can be there for hip replacement according to the approach. So I picked this one, tamam. Why I picked this? Because if you didn't bring down his trouser, you will not see the scar. So always remember, whenever he mention a surgery, you should look for the scar. So the scar, do you want to comment on the vitals? Borderline blood pressure, right? So borderline blood pressure, 2 scars, gingival hypertrophy, mild to moderate anemia, flapping tremor. There is no signs of overlap. There is signs of graft rejection in the form of tenderness. Did you find any uremic sign other than the flapping tremor? No. I kept for you only this one. There was no uremic froth, no itchiness mark, no
Nausea.
weakness or proximal myopathy. There is nothing else, only flapping tremor I kept for you. طيب, okay. Now tell me, what is your differential diagnosis for decreased urine output and nausea in this gentleman?
I think this is chronic graft failure. And
Chronic graft failure. Okay. My advice to you, don't specify chronic, acute, don't specify graft failure. We will speak about the timeline. So graft failure, what else?
maybe some drug toxicity that leads to the acute renal failure.
Drug toxicity. Okay, what else?
Maybe UTI or pyelonephritis.
UTI is a type of infection. So again, don't specify. It can be cytomegalovirus, can be Epstein-Barr virus, it can be UTI, it can be any kind of infection, right? So infection, including UTI, agree with you, but don't mention UTI because he told you I don't have burning micturition, I don't have fever. You missed the lymph node in the examination. Just commenting on this, I don't forget later on.
Yes.
So graft dysfunction or graft rejection, infection, drug toxicity. Did you notice that he lost a lot of weight?
Yes, he lost a lot of weight. That
What
is
you can add to your differential?
so it may be lymphoma.
Yes, I agree with you. Again, mention it, malignancy. If we will take the transplant and the immunosuppressant drug into account, we can think of lymphoma, there is skin diseases, there is many things, okay? Malignancy related to transplant and immunosuppressant drug. So this is your differential. I totally agree with you. Okay, dear, what is your investigation?
So right now I have to do the urea creatinine level that might be raised. I'll do the ultrasound to see the kidney pathologies.
Let's
Maybe
finish
there
the blood test first. Okay.
Okay.
What blood
I'll
test?
do this.
Mhm.
Okay. I'll do the complete blood count. Look for anemia, sign of infection, and if there's malignancy like lymphoma, maybe lymphocyte count will be high, eosinophil counts will be high.
That one is
And
leukemia, not lymphoma. So in the lymphoma, you will not find much in the CBC regarding the leukocyte, right? But at least I agree with you that you might find some anemia, you might find some kind of leukocytosis if there is any kind of infection, left shift, something like this, which can guide you through the differential. What else?
okay, then I'll do the ESR. It will be high. It might be high. I'll do the CRP and serology for cytomegalovirus. And then also do the, if there is lymph node, though I have not checked, but if there is any lymph node, I'll go for lymph node biopsy and histopathology.
Okay.
And for scan, I'll do the ultrasound to see the graft, whether it is
Only
functioning or not.
ultrasound with what? With Doppler?
Ultrasound of
With Doppler.
lower abdomen.
Okay, what else?
I might go for CT scan
CT
of
scan
abdomen.
of abdomen? Looking for what?
Looking for kidneys and whether there is any other lymphadenopathy, intra-abdominal lymphadenopathy or any.
Splenomegaly to stage if there is any kind of lymphoma or you're suspecting, you can CT to stage the lymphoma and see if there is any spleen involvement, any the lymph nodes group which are involved. But it's not mainly for the kidney because nothing in the kidney will be visible or will help you in your differential. What else you want to do?
I want to do urinary
You want
and
to do
urine culture.
urine what?
Urine microscopic examination.
Okay. Urine analysis. What else?
and also the urine culture.
What else?
And you want to see whether there is proteinuria or not,
Agree.
and drug levels like tacrolimus.
Perfect, because it's one of your differential. What else? Do you want to do
Other
do you want to do LDH? Do you want to do blood
LDH,
film?
yes,
Have-
LDH for lymphoma.
Do you want to do lipid profile? Why
Lipid
you would
profile,
like to do lipid profile?
lipid profile for the side effects of drugs.
That's side effects. Okay, so the drugs, you will do the drug side effects and drug level. You will do ultrasound with ultrasound Doppler. You will do urine dipstick, urine culture, septic screening, because we said infection is part of our
Yes,
differential. You will
right.
do electrolyte. I wanted you to say electrolyte, and what else? This guy have kind of kidney failure, and I want to look for the acute, for the indication of acute dialysis. So I will do electrolyte and ECG. Okay, please
Yes.
don't forget. And
Okay.
finally, what will bring for you the final answer? Is it infection? Is it rejection? Is it
Maybe it's a
intrinsic?
rejection.
What? No, I mean, what investigation will give you the definite answer?
Oh,
Is it infection? Is it rejection? Is it intrinsic kidney disease or drug-related toxicity? So what will give you the final answer for which differential you're dealing with? The most invasive test, which you didn't discuss even with the patient in the closure.
I think kidney biopsy.
Yes, kidney
oh,
biopsy.
kidney biopsy. Sorry.
So you mentioned lymph node biopsy, but you forget the kidney biopsy, so remember, okay? And you can say malignancy screening, the tumor markers, the lymph node biopsy, the LDH, the CT scan, all those are under malignancy screening. Infection screening, you mentioned the serology. Okay, definite investigation biopsy. Why this patient have hip replacement?
Yes, why this patient has gone? Maybe he is on steroid for long term for any kind of.
MashaAllah. For any kind of what? Continue. You're doing great. Guys,
Yes,
don't give her the answer. Me and Dr. Bath.
She said it. Yes, I thought she said it, but she didn't mention what the indication for
Let
steroids.
her brainstorm. Let her enjoy the case.
But
Okay,
she
so what
said it
steroid
already.
can
She said for the steroid use.
she
She
said,
didn't.
yeah, half of she's in the half of the
Okay.
way now.
Okay.
So what is the complication of steroid that can end up with hip replacement?
Well, this is avascular necrosis, but I
Yes.
forgot why did she taking steroids for long term.
Yes, you can say avascular necrosis, okay. And very good question that you ask about the etiology of the kidney transplant. It's really part of the calibration, and it was a very smart question. I don't care too much whether you ask it at the end or at the start, but always remember that any kidney transplant, any kind of transplant, any kind of intervention, gastrostomy, gastrectomy, hip replace. Why? Just ask why you did the surgery. Okay, I gave you the surgery and you asked me, did you do any surgery in the past? Now your job, any medication, why you are on this medication? Any surgery, why you did the surgery? Please, etiology is very important. We are done with the investigation. Now tell me how you will manage your patient.
All right. First of all, I need to admit this patient, and then I will, as there is acute renal failure, so hydration. I should maintain the hydration and proper keep an eye on urine output properly, input output maintenance. And if there is infection, I will give the antibiotics. And if there is then according to the etiology, I'll correct the
Only you will give
electrolyte.
antibiotics for infection, only antibiotics, or antiviral?
Antibiotics.
Yes, antivirals also.
Antiviral or antibiotics? Okay, what else? So infection, fluids, urine.
Infection, if it is virus, so mostly I have to
Yes, why I'm
antiviral.
reminding you, because cytomegalovirus is a big etiology here, so it's not only antibiotic. I have also sometimes we give empirical again cyclovir until we prove whether it's cytomegalovirus or not. So treating the infection here is slightly different than the usual. Usually infection antibiotic, but here I should keep antiviral in my mind. Okay, what else?
Okay, then I'll correct if there is any electrolyte imbalance. And yeah,
If there
and
is
then
any acute, if there is indication of acute dialysis, I will give a session of hemodialysis, right? Flapping, tremor, if there is drug toxicity, if there is any kind. So I will monitor for the acute indication of dialysis. This is very important. What else?
all right, then according to etiology, if there is
What? Yeah, you
there
mean
is
if infection?
malignancy.
If there's a malignancy, do you know, give just broad lines. If there is a malignancy, we'll treat the underlying malignancy. How? Just one word. By managing what? Before you mention those things, which team you should involve?
Multidisciplinary team I have to
This is a very vague term. You are dealing with a transplant case. I would love to hear a specific team.
okay, transplant team.
Yes, transplant team, transplant nurse, along with the other multi-speciality team. Okay, and those people will manage. If it is malignancy, what they will do?
Oncology department.
Decrease the immunosuppressive. If it is rejection, what they will do? Increase the immunosuppressive dose, especially if there is no toxicity. And if it is infection, we will manage the underlying infection. Okay. So those the broad lines, because whenever it's a malignancy or PTLD, post-transplant lymphoproliferative disease, it's very, very dangerous to increase the immunosuppressive. Rather, you should decrease the immunosuppressive. So it is the broad lines. Usually for malignancy, we will manage the immunosuppressive by modifying the doses, mainly minimizing the doses. If it is rejection, we will maximize the doses according to the tolerance and while monitoring for toxicity. طيب, what else I want to tell you? This still now there are some, you know, fixed lifestyle management, avoid nephrotoxic drugs, right? Dietitian, as we said, those fixed cliche for any renal case. Okay, dietitian, nephrotoxic vaccination, those you should enumerate them. They love to hear the nephrotoxic drug, the vaccination, the transplant team, transplant nurse, supportive teams. All those things are very important as a long-term management plan with monitoring and follow-up. And what if it is cytomegalovirus? We mentioned drug toxicity. You will involve the transplant team to modify the drug doses, and even sometimes they need to change. طيب, we are done with the management. Anyone want to add any good Viva question for this case? Well, we ask everything. طيب, tell me, we are done with your Viva questions. Now let's comment on your communication skills. طيب, not first skill, I think this is the third skill. I kept for, just let me share my screen. لا, I cannot share my screen.
Okay, I will try to let you do.
عاصم, أعطينا البرميشن, الله يسعدك. Anyway, let me read for you until I can.
Yeah,
So
you are host now, Dr. Hind. You can share.
let's see, and then I will share with you the table. Sure. Yeah, share screen. طيب. For the clinical communication, focused history on the renal transplant as a symptom suggests this could be infection. You didn't ask me about any recent upper respiratory tract infection. lower burning micturition, you ask. Cough, because it can be sometimes cytomegalovirus can cause pneumonia, right? So pneumonitis, cholangitis, colitis, retinitis, those are the cardinal signs of CMV. So you have to ask about the eye, the lungs, yellowish discoloration, change in the bowel habit. At least one question from every system, screening for any possibility of cytomegalovirus. I picked for you those symptoms. Okay, rejection, nausea, you analyzed whether it is related to the meal, affecting appetite. Okay, urine output, you analyze the urine, local signs. But please, please, it's very good to ask whenever it's a renal case, any periorbital puffiness, swelling around the eye, frothy urine, loin pain. Okay, I was very happy when you asked about the back pain. Sometimes they give back pain in the renal rejection. Okay, so this was a very good question, but I don't know why you didn't ask me about joint pain. You asked about back pain, but you didn't ask about joint pain. I was going to tell you about my gout and those things when you asked me about the joint pain, but you missed that question. Tummy tenderness, because it's a sign of graft rejection. Uremic symptoms, encephalopathy. You asked me about the headache. You didn't ask about convulsion. You asked me about loss of consciousness. You didn't ask about dizziness. You didn't ask about sleep pattern. Okay? So remember those questions for encephalopathy. Dizziness, convulsion, sleep pattern. Okay? Itchiness you asked, chest pain you asked. اتذكرت symptoms ونسيت. Overload. ما شاء الله, you asked me about the overload. Lower limb edema, you forget to check the JVP, you check the bibasal crackles. Okay, but you asked me about the shortness of breath. So fulfill it history-wise and examination-wise. Then should cover constitutional symptom because presence of significant weight loss is worrisome for malignancy. Okay, night sweat, appetite, I volunteered when you analyze for nausea. Immediately when you ask about weight, the next question should be appetite. So appetite, lumps and bumps, night sweat, weight loss. Pallor, fatigue, because those are the B symptoms and you have a kidney transplant case, so you should fulfill all of them. The cause of the renal transplant is ascertained. MashaAllah, you did this, okay? The candidate explored the use of the immunosuppressive medication that the patient was taking and any side effect. Avascular necrosis, you had to ask me why you did hip replacement. And gum hypertrophy in the examination, tremor in the history, lipid profile in the investigation. Try to fulfill the side effect in every aspect of your case. History, examination, and investigation. طيب, differential diagnosis, you did it nicely. Let's go up. Physical examination, focus should be on the abdominal system and integration of the transplant, looking for the tenderness, sensitivity, by asking sensitively by asking and observing the patient and listening for a bruit. Fine, alhamdulillah, but I triggered you. You might find this in your feedback that the candidate was prompted to auscultate for bruit. Always remember that the steps of the examination are inspection, palpation, percussion, auscultation. If you apply those four for everything, for the joint, for the lump, for the mass, for the gland, thyroid gland, you will never forget. Always remember, look, feel, move, functionality. Those work very well for the joints. And for anything else, inspect, palpate, percuss, and auscultate. Sometimes we skip some of those steps. But if they are your fixed step, you will never forget. Mass, I should inspect the overlying skin. I should palpate. I should percuss. I should auscultate. خلاص, simply, no need to actively think. Together with a close assessment of the fluid status, you forget the JVP of the patient is of utmost importance. So blood pressure sitting, standing, JVP, bibasal crackles, pitting edema, those are very important. The fact that the patient has had significant heart surgery, forget this, I didn't give it to you because this guy, mashallah, In addition to all those positive findings, he have also valve replacement and he's on warfarin. طيب, identifying physical signs, vitals, anemia, you said, medication, gingival hypertrophy, mashallah, you picked, abdomen and joint replacement, you picked, positive, negative graft tenderness, you picked, metallic, click, forget, no uremia, no overload, maybe there is positive, negative flapping tremor, or tremors. You have to do two things, tremor, outstretch your hand, separate your finger for the tacrolimus and calcineurin inhibitors in general. Then you cock back the wrist and check for flapping tremor. تمام, clinical communication we finished, differential diagnosis we finished, clinical judgment investigation, avoid nephrotoxic medication, admission. Please, whenever there is a transplant case, the transplant team and transplant nurse are as important as mentioning the Macmillan nurse in communication. Tissue viability nurse in cases of ulcers or bed sores. Some terms are vital terms, not only MDT. MDT will not save you here. Will I lose my graft? I like your diplomatic answer that based on the parameters, markers, monitoring you, we can decide if you are recovering or if your kidney are getting worse. And it's important in the closure to tell about what? Which kind of invasive investigation you have to discuss. And most probably, yes, kidney biopsy. تمام? Should be addressed in the consent. طيب, maintaining patient welfare, you did everything for the welfare. Okay, did you like your case?
Yes, yes, thank you so much because renal case is very important for me since I got the seat at Kathmandu, and you know renal patients are most important for me. Thank you, sir. Such a nice elaboration.
If it is important for you, then we can continue the viva question of the clinical stage, because usually they are in love now of bringing the cases which usually in the clinical station in the LCC. If I show you this picture, which is on the WhatsApp now, what additional physical sign you will add? Tattoo. Okay, always keep an eye on the tattoo because tattoos usually are important clinical sign. Okay,
Yeah, okay.
don't
Got it.
ignore it. Okay, and there is also a drain. There is a drain scar. There is a reverse J scar. Okay, so always keep an eye on the scars, the drain scars, tattoo. Okay, stria marks. Yes, I forget to write even. He's on steroid, interscapular fat pad, stria, proximal myopathy, plethoric face, Cushingoid face. Okay, those are bruises. Okay, thin skin. So sometimes you might need to pinch the skin. You might need to do the proximal myopathy. You might check the back of his neck. You need to check the abdomen, especially the sides. Sometimes the stria marks are only in the sides. They are not in the tummy from above. So check the sides. Okay. And what else I wanted to tell you? Yes, that's it. So steroid signs are very important. So don't save. What I want to do for you also. So if you guys like are awake, if you want to revise the Fiverr question, we can revise them. Otherwise, I'm done with the case. Anyone want to comment? Did I forget anything? Did we miss anything? Any experience?
No, Dr. Hind, mashallah, you covered the topic well from A to Z. The complication, the investigation, the management, everything you cover, mashallah. By the way, Dr. Tanya did well because she did this first trial, right, Dr. Tanya? First practice?
I am not in practice so much, and it's almost
No, I
my
mean
second
in this
time.
meeting, yeah. I mean, you didn't do
Yeah,
before
in
with me.
this meeting,
Yeah,
Just
yeah,
meeting this.
but really, you did great. With this level, you are more than beginner. Really, you did the great. You reached to diagnose. You ask a lot of questions, and the case is very complicated. Dr. Hind always bring such case of interested cases. How to
والله
approach? Yes.
يعني case of renal transplant is common
Yeah.
بس يعني it was full of signs وترى الكيس
Yeah. Yes.
يعني pass test اختي الكيس بس طبعا جايبينه abdominal pain يعني it was abdominal pain and nausea. The patient have also ما شاء الله
A lot of
aortic
finding.
aneurysm and cardiac. But what I find very nice guys إنه usually when they did the calibration and when the examiner was asking, they were not interested in the warfarin side effect and the diet and the yellow book and those stuff and drinking. They were interested in the complication related to the complaint, and the calibration were made mainly on the renal. So don't be, distracted by some additional finding if your case is renal. The heart will be additional signs, maybe metallic click scar. Okay, that's it. And you can tell the examiner when you are mentioning the management that I would like to counsel the patient and make sure that he's following his INR, he's aware of the diet, to the examiner only. Don't waste your time in the history to ask those because they are not related. The patient don't have bleeding and his decreased urine output and nausea are not related neither to his heart nor to the warfarin. It's not a bleeding case where you have to take a detailed history of warfarin. So the beauty of this case, which I learned two things. Imagine in past test, the candidate was negative for everything, no overload, no uremia, no flapping tremor. And when the candidate was telling the examiner that no, so the examiner, he asked him how you can explain the discrepancy between the history and the clinical findings. Simply, you can tell that we cannot exclude based on the examination only. I still need to look into the investigation and take the history into account. That's it. This is your answer. But don't invent signs because your history is positive. I like, really, if anyone have time, go and listen to the case. It was very nice. So this is the first learning point. Don't invent, okay? Even your history is suggesting a uremic or transplant failure, but don't give any false signs. And really, in this case, there was no signs. And he asked him this question. He said, I cannot exclude based on examination only. I need to look into the investigation parameter and take the history into account. And second learning point, that don't be distracted by additional findings. They are positive physical signs, but they should not distract you in the history, okay? They are still a positive physical signs. You have to mention the scar of the cardiac surgery, but it should not waste your time taking additional history. Then it will not affect your communication skills if you ignore those additional points, but try to compensate when you discuss with the examiner. And please, yes, we forget something. You have to look into the fistula. I was asking you. You have to look into
Yes,
scars in the neck for any previous lines, fistula, scars, closed fistula, functioning fistula, which is not recently used. And my advice to you, always screen the elbow, screen the cubital fossa. Always remember, you should never skip these two areas. Never, try really to bring his arm up, check the elbow from down, check the cubital fossa, venipuncture, needle marks, AV fistula, anything can be there, okay? What else I want to tell you? So those things are very important in any renal transplant case, okay?
Can you please repeat that? Am I losing my graft? What should be the answer?
The answer should be that it's early to decide whether you are losing your graft or not, but we need to admit you urgently. Wallahi, the word urgent, it was a big mistake. I didn't even mention it in the calibration. We need to admit you urgently, okay? Urgent admission. So to and investigate you. We will involve a multidisciplinary team, including the transplant team, who are expert, okay, in assessing your condition. And based on your kidney markers and the response to treatment and the biopsy results, طبعا you already told him we'll take a snip, we can decide, okay, about the condition of your graft. But I can reassure you that we will do our best to save the graft, but there is a possibility that you lose your graft because of the current attack. Still, it's a possibility, but we will do our best to save it, and it's early to tell whether whether currently you have lose it or not. But there is a possibility if you didn't respond, and if the attack is severe and have badly damaged your graft, that you cannot recover its function. So always keep this possibility, but for now, it's early to tell. Still, we can do a lot of measures to save it. And mention urgent admission, mention the transplant team, mention the biopsy, and then mention the possibility of losing the graft function. Okay, after doing all those measures, and still there is a possibility to lose it. And we will keep you under monitoring and follow up. Okay.
Yeah, clear, Dr. Hind. Thank you. Very nice case and interesting one.
And
Thank you,
please,
Thank
I
you
will
so
not,
much.
I forget to comment about the recreational drug, allergy, any change in the drug, any recent change in the doses. Those are, especially whenever I deal with someone who recently, or just now you said, I have a scheme. Follow your scheme. You didn't ask me about any changes in the drug doses, okay? Did you add any medication, any new painkiller, any started or stopped medication? What if I started a painkiller or antibiotic which interacted with my immunosuppressive medication? What if I stopped steroids suddenly? Right? That's why I have abdominal pain and nausea. I can just by one question
Crisis.
turn your case into Addison crisis. Right? Nausea, abdominal pain, postural hypotension. It's an Addisonian crisis. It's not a transplant rejection. So please, please take care of those things. Okay?
Yes,
Yeah.
clear, clear. Thank you.
عملنا calibration للكيس 3/4 calibration nice.
Yes,
So take care of those things and keep them in your mind. تمام?
yes. Okay, any question? Thank you, Dr. Hind, again for the case. Any question, Dr. Tanya, for this case or for any?
It was
for
very
any-
amazing.
Yeah. Any question from others, please? Any doubt about this case or the previous one?
Dr. Bassel, I just want to add a comment.
Sure, Dr.
Thank you very much for the case. It's a very good case, and kidney transplant is actually popular everywhere, every center.
Yeah, even in the
Actually,
short as abdomen, it's not only for long.
yes. So I just want to tell you that we have one case actually. It appeared just last night, and the patient had a renal transplant and the same double valve replacement, aortic and mitral. And they will ask you what is the relation of the renal transplant to the heart problem, to the
Yes.
heart replacement.
Perfect.
Polycystic kidney disease.
Yes.
So,
Perfect.
what is it?
Polycystic kidney disease and mitral valve prolapse.
Exactly.
Not really,
Yes.
not really. Find another, because in polycystic kidney, you will find at least a palpable side. So this was renal transplant in one side. But if you palpate the other side, you cannot feel any cyst, you cannot feel a palatable kidney. So what other differential can you think of? I mean, this is a differential, you are right, but it's not the case.
You mean another collagen disease? Or
No.
طيب what is the etiology of the kidney transplant? He might have some
This
toxic.
is their question.
Yeah.
This is their question. They're asking you this question to know what is the etiology.
Yeah.
So they will ask you what is the relation of the renal transplant to the heart replacement. So in another way, they're asking
rheumatic heart disease. Could be.
No.
Yes.
It's infective endocarditis. So actually, the cause for the renal failure was infective endocarditis leading to glomerulonephritis, immunological phenomena leading to failure of the kidney, and then transplant. So so it can be related. So be careful.
Yeah, rheumatic also. I think rheumatic can affect the kidney, both streptococcal and also rheumatic heart disease, the valve itself. So it might be related in
So they
indirect way.
expect this deeper thing from within 20 minutes from us, right?
No, 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 no. By the
Don't
way,
be
you cannot.
scared. Don't be
Yeah,
scared.
yeah, no,
This
you will
would
not
be a
reach to this
bonus
level.
question. If you did
Yes.
see, you should be a safe doctor, irrespective of his etiology. You need to save this guy. Overload, uremia, drug toxicity, whether he's have rejection infection. This is the main thing. To save the graft, to save the patient. Whatever the etiology, whatever the accessory thinking, it's gonna be a bonus question. But why why we are now on دكتورة ريان مين اللي كان عم بيقول we on here something
We're just
fresh.
sharing ideas.
Yes,
يعني
because she shared it with us, so at least now we will not be surprised by this question. But let's say you didn't get any idea about this. No, you will not miss marks if you fulfill their calibration. Just have a basic scheme for the renal transplant, for renal failure, for exploring the previous RRT methods, for exploring the side effect of medication, admit the patient urgently, involve the correct teams. Do you know if there is any nephrotoxic drug, any unsafe measures ongoing to stop that? Start him on the proper management. You are safe, you are done. But these additional things, really, it's valuable. Whenever you hear them, don't get scared, but keep them in
Yeah.
your notes
Yes.
just to
Yes.
be
Exactly.
ready to have the bonus question.
Yeah.
That's it.
Yes. And
Can I
also,
get the recording?
Yes,
sorry.
our recording. Dr. Basim is doing a great effort, not this recording only, the recording of 1 year, dear. You can get it all on the YouTube. So
Yes,
thanks.
I saw lots of videos in YouTube,
you will
and
find
that
also.
is why I'm interested.
والله الله يسعدك يا دكتور
Most
باسم.
welcome. You
فرصة
deserve.
نشكرك من الأعماق.
Thank you also for your sharing and all participation. I really I am with you, and this meeting by you, not only me. So the effort by the participation and being with me, the attendance. That's why this meeting is precious. Not only by my effort, no, by all of you. So I really thankful for all of you, not only my effort. I mean, this is your work, and this is the also what we are getting by your participation. Of course, sharing the efforts and sharing the practice experience from everywhere. By the way, one question you might remember it in the exam by like Dr. Ryan did. She brought the experience from somewhere. You might face the same examiner because they are roaming
with
everywhere.
the same question. والله معك حق.
Yes,
That's
yes,
why really the parties one question can really change your whole station.
yes, exactly. And it might be, as Dr. Hen said, the bonus question for the full mark. And he might change the whole performance by this question. He will know that you are expert and confident enough to answer this question. By only listening to this question in a session in such time after 12 a.m. in a night, all participants or some of a participant are sleeping, but you wake up to hear this discussion or at the recording. I mean, some information you might hear it, and it
Can
will
really
help you.
much help.
Excellent
Yes,
session, sir. It is excellent session. I'm really happy. At last,
most wel-
I got you.
most welcome, Dr. Tanya. Anytime, just message me if you want to practice again. We are doing as usual pattern. One day for the long, the next day for the communication continuously, inshallah. Hopefully, it will not stop this meeting, بإذن inshallah. Okay,
بإذن الله تعالى.
inshallah.
And please أي حدا عنده مثل دكتورة ريان سؤال حلو.
Yes.
عزيمة على الأسئلة الحلوة.
Yeah, anyone
Dr.
has
Hen,
question
you have
from,
the best.
sorry?
I am telling Dr. Hen that the case was wonderful. I'm very thankful to her.
Anytime, dear, anytime. And I remembered one question. What is the differential diagnosis of abdominal pain in such a case?
Yeah, nice question.
Addisonian crisis.
I agree with you since he's on steroids, especially if there is a history of stop, but keep it later on because you need a history of withdrawal of steroid. What else?
What else?
Rejection, as you said,
Yeah,
rejection.
rejection, infection,
Infection. What is the last one?
recurrence.
Recurrence will not cause a tender kidney.
Mhm.
Intrinsic kidney disease. What else? هي thrombosis.
Yeah, thrombosis to the
عشان هيك
vessel.
احنا عم نعمل
Yes.
دوبلر. فثرومبوسس infection يعني حتى كنا نقول infection rejection. فالinfarction بين قوسين مقصود فيها we mean by infarction thrombosis, so you can يعني the rhythm can help you to remember. So infarction, infection, rejection and infection. Infection قلنا هنن ثلاثة. والأديسونيان crisis as a part of metabolic. تمام. So the drug toxicity sometimes it's considered to be a metabolic or uremia. فالmetabolic causes of abdominal pain, Addisonian crisis, uremia or drug toxicity, plus local causes اللي هي related to the graph, infarction, infection rejection. تمام. Those are painful. فالثرومبوسيس والinfection rejection. تمام. those are this is a very good question يعني what
Yeah.
is the cause of abdominal pain in such a case. والscars يعني they love to ask about the scars. We took the hip replacement, the reverse G scar, peritoneal scars, laparotomy scar. Why laparotomy scar in such a case? Especially if there is a peritoneal catheter scar.
Previous dialysis, peritoneal dialysis.
Peritonitis usually.
Yeah, SBB.
Yes.
Yeah.
SPB or secondary peritonitis or
Mhm.
the encapsulated شو كان اسمه هذاك encapsulated peritoneal sclerosis. اختراع من عندي مو هو متذكر هذاك السنة لأنه it can lead to the need to remove the catheter or sometimes they do laparotomy. this is a kind of a scar which you can see there. الهارت مثل ما قلنا لو which indicate الاتيولوجي أو مثل الكيس تبعي. أنا الكيس تبعي ترى بpass test aortic aneurysm. فmust probably he have a kind of collagen disease, vasculitis, something like this, which affected the led to aneurysm, aortic root aneurysm, aortic valve replacement, and affected the kidney. This was the past test case. Dr. Rayan, she added for us infective endocarditis. Dr. Tanya, she said APKD. Remember, إنه heart can be involved. I can have a closed AV fistula or functioning AV fistula. I can have scars in the neck. طب if I have a scars in the face, what it will be? Take small scars with two one stitch.
Parathyroidectomy.
Parathyroidectomy in the neck.
Okay.
In the face, in the upper chest, in the sun-exposed area.
Yeah, cancer. Skin cancer.
Yes, from the immunosuppression. So you can have parathyroidectomy, punch biopsy أو excisional biopsy for those skin cancers, AV fistula, neckline. You can have a scar in the back, indicating what?
Nephrectomy.
عليك نور, nephrectomy. So take care of the scars, please. تمام?
Yes. Thanks, Dr. Henta. Yeah, go ahead.
What is the differential diagnosis of right iliac fossa scar?
Yeah, nice question also. And a common question. Dr. Tanya. Anyone has the answer? Right iliac fossa scar.
Okay, renal transplant, appendicectomy.
Yes.
Never ever forget gynecological causes. He is a male. But believe me, even if he is a male and you were asked this question, gynecological causes, maybe malignancy, cyst, whatever. Gynecological, colon, could be appendicitis, could be cecal mass, could be volvulus, could be anything, could be
Crohn's complication
Hernia
also.
as well.
Yes, so
Hernia
you have to
repair.
mention hernia repair. So colon, wall, the hernia considered part of the wall. So go by layers.
Mhm.
So it could be a wall problem, hernia, could be colon problem, could be gynecological problem. See, another advice, never ever mention transplant alone. Transplant or donation. Transplant or donation. Both of them will have a scar. يلي بيعطي واللي بياخد. Who give
Mhm.
and who take. تمام؟ الاثنين
Yes,
حياكلوها، الاثنين حيكون عندهم سكار. So
exactly.
transplant and donation, الhernia repair, colon surgeries, whether appendicitis or cecal or whatsoever, and or kidney transplant or kidney donation. What else? So this is very important. تمام؟
بس
Yeah, Dr.
دكتورة
Hind, please,
هند
you can mute, please, because you are the host
صح.
now. Can you
حاضر
mute?
عيني.
Yes. Yeah, who has the question, please? Go ahead.
I just wanted to ask دكتورة هند transplant donation it will not be right إليك فصة صح؟ هيكون nephrectomy scar then
Yeah, at the
صح؟
back, yes.
at the back yeah.
قصدك الدونر ما حيكون صح كلامك، الدونر ما حيكون، بس بالليفر ترانسبلانت بينفع لأنه نفس السكار. بالليفر نفس السكار الدونر والترانسبلانت. بس بالكدني I agree with you إنه اللي حناخد منه الكدني ما حيكون رايت إليك فص سكار، حيكون نفركتومي سكار، حنشيل الكدني ونعطيها للدونر. You are totally right. بس أنا بصراحة للأسف يعني وقعت بالفخ، أنا دائما بخليهم مع بعض، بس بالكدني you should be careful إنه it is different scar. بس بالليفر it work. بالليفر the same scar. تمام؟ بس remember the donor will have a scar and the transplant will have a scar. يعني thank you for pointing this out. تمام؟ what else؟ بس يعني هدول الأشياء اللي خطروا ببالي scars, the differential diagnosis of the scar, differential diagnosis of abdominal pain.
Yes.
شكرا كتير على سؤال الإكسبيرينس. شكرا كتير دكتور باسم على السيشن الحلو.
I'm most welcome, Dr. Hind. Thank you again. Thank you, everyone. Thank you,
Thank you
Dr.
all.
Jamil, for participation today. Yeah. Any question from others before ending the session? Dr. Tabassum asked for the differential. I wrote it in the chat box for the first case, subarachnoid hemorrhage, ICH, venous thrombosis. You can mention meningitis if you suspect infection, and our case, pituitary apoplex. These are the causes of acute headache with increased intracranial pressure. Okay, in any station you can mention them, and you have to rule out every one of them during the history taking. Okay. Any other question? Thank you, Dr. Aisha. Okay, see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, sir. Assalamu alaikum.
Alaikum assalam.